I'm going to turn this over to our speaker, Dr. Jennifer Goralski.
Thank you. And I'm only too happy to keep my video camera turned off as well, because there's nothing more distracting than seeing yourself in the corner of your screen. But if you want me to, I'll turn it on. It's fine.
Yeah, if you don't mind to turn it on, that would be great. Just for
I got excited. I was like, oh, there's permission to not have to look at yourself as you're talking. Great. Okay, but I totally understand. I am not great about balancing the chat with the presentation slides. So we will certainly go back to the chat afterwards and pick up any questions that were shared in there, if that's okay. And I'm going to share my screen. And please, someone let me know that you can see the PowerPoint presentation.
Yes, we can.
Thank you. Okay. Thanks everyone for coming today. My name is Jennifer Goralski and I'm at the University of North Carolina at Chapel Hill School of Medicine. There I am a faculty member in the Department of Pulmonary and Critical Care and also have an appointment in pediatric pulmonology. And I'm the associate director of our adult CF clinic there. And I'm going to be speaking to you today about cystic fibrosis and cardiovascular disease. And I call this "It's Time to Pay Attention." And thank you so much for the organizers for inviting me to speak with you today. I think this is a really important and timely topic to bring to the group. So I have a few disclosures that they require us to talk about, none of which relates to any of the content in this presentation. But just so everyone is aware that I do receive grant support from my investigator research from both the CF Foundation and the NIH. And I get clinical trial funding for conducting clinical trials in CF research from Vertex, Savara, and Boehringer Ingelheim. And I have served on a scientific advisory committee for a company called Polarian. And I do not believe that any of those would have an impact on the content that I present today. So here's an outline of what I'm going to talk about over the next few minutes. We're going to start with a case presentation because I always think that's a really good way to introduce a topic. Most of the things that we find ourselves interested in as physicians and medical providers do come from patient experiences. And then I'm going to give you a general overview about heart disease, talk about some risk factors, those that are specific to women and those that are shared by both men and women. We'll talk about symptoms, some preventative strategies, and then have some time for question and answers. And I like this quote from Steve Jobs, who said, "Picasso had a saying, good artists copy, great artists steal, and we've always been shameless about stealing great ideas." And so I do participate in quite a few quality improvement projects, and we are all about stealing shamelessly, which means I didn't create any of the graphics that you're going to see in today's presentation. I gave credit where I could from the various websites, but the majority of the information was taken from Google search and the CDC, the Center for Disease Control, the American Heart Association, and the National Institute for Health. And you can access any of these graphics those ways, but I'm not trying to claim that I created them. So let's start with talking about the patient that prompted this investigation. So this was recently published in the Journal of Cystic Fibrosis, and the title of it was Acute ST Elevation, Myocardial Infarction in 2 Young Women with Cystic Fibrosis and CF-related Diabetes. Acute ST elevation myocardial infarction is our official way of saying a severe heart attack that's caused by a blockage of one of the coronary arteries that leads to heart damage and can be fatal if not treated. So what unfolded was that our on-call physician, who was Dr. Despotis, who's listed here as one of the authors, she got a call from a patient at 6 or 7 o'clock one evening. And this patient was a 31-year-old patient with CF, and she had CF-related diabetes. And she said, didn't want to call. I'm not really sure what's going on. I've just had this, vague chest pain for a day or two, and it doesn't seem to be getting any better. And it was making me a little short of breath, but like this doesn't feel like my typical exacerbation. I think it might be reflux related because it seems to get worse when I eat. What do you think I should do? And so Dr. Despatis, in her wisdom, started thinking, like most physicians do when we receive a call like that from a patient, and say, well, what's the differential diagnosis? What could be going on with this patient? And she thought about, whether or not the patient was experiencing an infection or maybe a lung collapse, a mucus plug, or was she right in that this was severe acid reflux, which can certainly cause that type of chest pain? Or had the patient been coughing and pulled a muscle? And she said to the patient, there's just not enough information that I can get over the phone. I'm a little worried about the way you're describing the pain. I'd like you to go to the emergency room, which is, of course, the last thing anyone wants to hear when they're calling to try to get advice on a medical condition. But unfortunately, sometimes it really is the best approach. And in this particular situation, both the patient and the provider were very lucky that, she offered that recommendation and the patient actually took her up on it. Because the patient arrived in the emergency room. And one of the things that the ER does almost invariably when a patient comes in through the emergency room is to obtain an EKG or an electrocardiogram, which is a tracing of the rhythm of the heart. And through that EKG, they were able to detect that this patient was in fact experiencing a heart attack, and the severe version that we know and that we call an acute ST elevation MI. And so she was seen by the cardiologist and taken into the catheterization lab, where she had these images shot. This is a coronary angiography view. And over here on the left, this is an image where the cardiologist will inject her coronary arteries with this dye that highlights them. And then they know the normal anatomy of how those vessels wrap around the heart. And they were able to detect that right here, there was 100% occlusion of this vessel, something called the left anterior descending artery, which is one of the major blood supplies for the heart. And because it had been going on for a little bit, the patient actually already had these little extra accessory vessels that we call to compensate because she had this blockage going on for some time. So her heart was desperately trying to grow new blood vessels to overcome this area of blockage. And so the picture over here on the right is a slightly different view, a little twist in the screen here. But this is what happened when they went in and they revascularized this artery. They were able to open up that obstruction over here and allow for the blood flow to recirculate to the rest of the heart so that she no longer needed to depend on these collateral vessels. So really, what is atherosclerotic cardiovascular disease? Well, it's kind of a bucket for a lot of different medical conditions. The one that we generally think about is something that we term coronary heart disease, or CHD. And this is related to heart disease that's caused by a problem with the coronary blood vessels. And so it includes the subcategories of heart attacks, both the ST elevated heart attacks and the non-ST elevated heart attacks. And that just simply describes how much of the vessel is occluded and how. And also angina, which is the chest pain, the medical term for the chest pain that this patient had been describing. Atherosclerotic cardiovascular disease also includes the term vascular, right, which includes cerebrovascular disease. So part of this, because it's all related to the same underlying pathophysiology, is the effect of strokes and transient ischemic attacks, or mini strokes as they're sometimes called. Much less common is something called peripheral arterial disease. And this is when somebody has cholesterol plaques in their lower extremities, in the arteries that feed their lower extremities. And what happens in those scenarios is those patients develop pain that worsens as they walk or as they move their lower extremities, because as you use your muscles, they require more oxygen. And if your vessels are already hardened or obstructed and more blood can't get through those vessels, it causes worsening pain, which we refer to as claudication. Aortic atherosclerosis is a term describing cholesterol plaques that are in the aorta, or the large blood vessel in the center of our body. And that can lead to abdominal or thoracic aortic aneurysms, which is a weakening of the blood vessel wall. It causes a ballooning out of the blood vessel, which then makes it more prone to rupture. And some of you may remember this is how John Ritter passed away. So this is a graphic I took from the CDC because heart disease has long been the #1 killer of men and women in the United States. And so just to orient you, they have here the top 10 conditions that contribute to death in the US. And then this is for every 100,000 people in the US, how many deaths were caused by this particular condition. And this is data obtained both in 2019 and 2020. And you can see by far and away, heart disease is the biggest contributor to death in our country, followed by cancer. And then interestingly, COVID-19. COVID-19 was first officially recognized as a cause of death in 2020. It wasn't a thing in 2019, right? And so we didn't have any data from 2019, but you could see how quickly it jumped off the charts and bypassed all these other causes for death. And so it is something that we need to be aware of or thinking of. And the CDC has really, really great information, and you can look at this in all sorts of different ways. I liked this graphic, which breaks down heart disease death rates. And this is a bit old data. It was about 5 years ago or 6 years ago. So, but this is for women who are 35 years of age and older by county that they live in. And here we see that as it's called a heat map, right? So as the color gets more intense, so does the number of patients who died related to heart disease. And you can see the areas of the country that are really much more impacted because of heart disease compared to other areas of the country. Heart disease, CF, really? Not us. Reasonable assumption, and one that we have long ascribed to, particularly those of us in the medical field. And the actuality of it is that heart disease has long existed in CF, although not this typical atherosclerotic cardiovascular disease that I was describing. So the heart disease that we've always experienced has really been a complication of severe lung disease and chronic low oxygen levels. So this little graphic over here, it just shows us the intimate connections between the heart and the lungs, right? So the primary function of the heart is to pump blood in through the right side of the heart and then out to the lungs to get well oxygenated blood. And then it returns back into the heart and it enters into the left side of the heart, where it then goes and gets pumped out to the rest of the body. And so they really have to work in concert in order to keep our bodies well oxygenated. And so in a disease like CF, where there's destruction and damage and bronchiectasis, you can develop low oxygen levels over time as those airways are destroyed. And then what happens is something that we call pulmonary hypertension, which means that this right side of the heart, which is responsible for beating and pushing blood out to the lungs, has to work overtime. It has to work doubly hard in order to be able to pump against these blood vessels. The pressure within these vessels gets raised in response to the chronic lung disease. And so this right side of the heart starts pumping and pumping and pumping, and it can be a relatively ineffectual pumping and cause fluid to back up. What is sometimes a side effect of this is that this is the right atrium, and our sinus node, which generates our heartbeats, is located right about here. And so if this right side of the heart is pumping, 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 and overexerting itself, because it's not supposed to be pumping that hard, you can actually distort the sinus node, and that causes arrhythmias or palpitations or skipped heartbeats. And so some people may have problems with their heart rhythm in addition to having problems with their the muscle of their heart. And then ultimately, if this if this isn't treated or slowed down the progression, you can develop what's called right heart failure, where essentially the right side of the heart just cannot pump blood to the lungs anymore to pick up any oxygen, and therefore the entire system backs up and oxygenated blood doesn't get to the rest of the body. And so that's the way we usually thought about heart disease in CF. It was more of a scenario in somebody with long-standing, very severe lung disease. Although there have been other case reports like the one I clipped here, which talks about the medication interactions that can sometimes cause different types of heart block or arrhythmias in people with CF. And so we were always kind of thinking about heart disease in CF. But not really atherosclerotic heart disease. In fact, this is not that old in terms of research letters. This is about 6 years old now. And this was a letter in the Journal of Cystic Fibrosis, which this group of investigators looked at all their patients with CF that were undergoing evaluation for lung transplant. And part of their center's requirements for lung transplant is that patients had to have one of these coronary angiograms in order to have a lung transplant. And so they wanted to make sure those blood vessels were healthy and not obstructed before they went and implanted new lungs. And so they went backwards and looked at all their patients that had been referred over a number of years who were above age 40, undergoing lung transplant evaluation, and they had this coronary angiography. And so they found 14 patients that met those criteria. 8 of them were male. They were young, about 47 years old or so, all had CF, different genotypes. And there's some information here about the severity and type of illness that they had. But they looked at the number of patients who had CF-related diabetes, the number of patients who had unregulated cholesterol problems, and what their fasting lipid profiles looked like. And they compared them to people who were not undergoing lung transplant. And importantly, what they found was, looking at these 14 individuals, none of those individuals actually had any type of narrowing or stenosis of those heart vessels, even though they had these types of risk factors, in some senses. And so this was reassuring that, okay, well, traditional atherosclerotic coronary heart disease is maybe not something that affects CF patients all that much. But as our case illustrated, this is kind of a question that's up for debate right now, and certainly something that we are interested in investigating further. So this was actually just published online, this review article from some folks overseas. And I like this. It shows a blood vessel here with a progression of an atherosclerotic plaque or a cholesterol plaque. And it talks about, within CF, the different types of protective or adverse risk factors that are either not modifiable or modifiable. And so coronary vascular disease begins with an injury to the endothelial cells that line the arteries. And then what happens is that little fat particles start to infiltrate in between the lining of the blood vessel. And then you get cells that come in after that. And then it progresses to the point where you can see just the narrowing of this blood vessel, right? And now all the blood is trying to push through this narrow portion of blood vessel. And eventually there can be so much that it either completely obstructs the vessel or it can make this vessel rupture. And so what these authors did was point out that within CF, we do have some protective factors, such as generally cholesterol levels are usually lower. We don't have a lot of people that smoke. Usually people have relatively lower normal weights and body mass index. But there are also some things that really we should be thinking about as potential risk factors. We talked a little bit about the pulmonary hypertension, chronic inflammation, CF-related diabetes, and even the novel CFTR modulator therapies. And of particular interest to a lot of us is the traditional high-calorie, high-fat diet. And so this gives us a little framework to think about how to address cardiovascular disease in the future. So let's jump into some risk factors. There's some that are common to both men and women, and I've alluded to most of these before. A family history of early heart disease, and so that's actually defined as heart disease detected in a man who's under the age of 55 or a woman that's under the age of 65. And that age differential has to do with the protective effects of estrogen. People with high cholesterol are at higher risk for developing heart disease, as are people with metabolic syndrome, which is defined as any 3 of these 5 criteria. So a large waist circumference, high triglyceride levels, high blood pressure, diabetes, and low good HDL cholesterol. So if you have any of those 3, you technically have metabolic syndrome as well, and that is an independent risk factor for developing heart disease. Chronic kidney disease and chronic inflammatory disease also play a role. And when we think about specific risk factors for women, autoimmune disease, which disproportionately affects women more than men, is an potentially non-modifiable risk factor. We're going to get into some details about menopause in a future slide, but early menopause, where you're not producing estrogen for as long as you should, is a risk factor. And interestingly, adverse pregnancy outcomes. And so if there's somebody who had preeclampsia during their pregnancy, which is high blood pressure, or gestational diabetes, or their child was delivered preterm, those are all factors that tend to predict the development of cardiovascular disease in the future. And unfortunately, both breast cancer and treatment for breast cancer tend to be risk factors for development of cardiovascular disease. Now, lactation, breastfeeding a child reduces the risk for future development of heart disease, and this seems to be related to those hormone levels. So one thing that I think is probably generally poorly understood and not well appreciated overall is just how much the effect of chronic stress and mood disorders have on the potential for development of coronary heart disease. So anxiety, depression, chronic stress, post-traumatic stress disorder, these conditions often lead to an increase in your cortisol, your stress hormone, maybe reduced blood flow to portions of your heart. Your heart is more likely to be reactive to situations. You sort of have heightened anxiety and your heart rate increases in response to that. Pain and fear, those are all contributing factors. And then what ends up happening is the development of these cardiovascular diseases. And of course, somebody with one of these cardiovascular diseases, they're going to be more likely to have anxiety and depression and chronic stress, and may or may not be more likely to engage in other behaviors such as smoking or physical inactivity that maybe worsens these risk factors. And so it really is an unfortunate vicious cycle. So this is one of those infographics I took from the American Heart Association. And what I like about this is that it says that 1 in 5 women will have medically significant anxiety or depression at any point in time. And so this 1 in 5 women, these severe mental health disorders can lead to unhealthy habits as people try to cope with their diagnosed or maybe undertreated anxiety and depression. And so they may overeat, they may smoke, they may be physically inactive, they may do other relatively unhealthy things, which then increases their chance for developing heart disease. And so they suggest other healthy ways of coping with stress that don't involve adopting one of these heart risk habits. I think that the birth control pill has been maligned for a long period of time and really misunderstood in terms of its contribution to heart disease. So there was a really extensive study for many years gone on called the Women's Health Initiative. And some of you may have heard about it in terms of estrogen replacement therapy in menopause. The oral contraceptive pill, which traditionally contains both estrogen and progesterone, may mildly increase your blood pressure, but it's generally on the order of about 5 points, which is usually not very clinically significant for people. However, it is known to increase the risk for blood clots, particularly when you start using them, when you first start on them, or if you're somebody who has other risk factors. And in fact, when they first created oral contraceptives, they used really high, about 10 times higher estrogen doses than what we use now. And in fact, at that point, more heart attacks and strokes did occur in those women who are on the oral contraceptive pills, about 1.6 times higher overall risk among those users of combined oral contraceptives. But what we need to recognize is that there's actually a really high risk for cardiac complications, both during pregnancy and in the postpartum period. And so this is when our hormone levels are really all fluctuating and up and down. It's often said that pregnancy is the highest stress that can be put on a person's body. And that's really true when it comes to the stress of the cardiovascular system. Pregnancy is high risk, postpartum period is high risk, and then the person who tries to prevent pregnancy by using an oral contraceptive may be at higher risk as well. So we're damned if we do, we're damned if we don't, just like a lot of other things that we can go through in life. So the CDC does recommend avoidance of hormonal contraceptives in particular scenarios. And so it really is a conversation between the patient and their provider about what type of contraceptive is the most appropriate for them to use. Because I think that there's, the pills are easy. And if there's, people are used to taking medications on a regular basis, pills may seem like the least obstructive one to start, but there really are some scenarios that you shouldn't use oral contraceptives in. And I actually love this graph. It's a little bit busy, but I ran across it when I was looking up some information for this talk. And this is from the CDC. And what they did was they categorized who was medically eligible for different types of contraceptives. And so they looked at things like the copper IUD and an implanted hormonal IUD. Implant refers to the Norplant, which gets implanted in the upper arm. DMPA is the Depo-Provera shot. POP stands for progestin-only oral contraceptives, and then CHG is the combination hormonal oral contraceptives, or the pill in classic form. And then they looked at a lot of different conditions, and look, they even looked at CF in and of itself, and they said, based on this ranking system, where green means no problem, medication can be used, and red means this should not be used at all. And then you have in between theoretical risks, or risk versus benefit ratio. You can see within CF, most things are pretty safe, as if CF was the only problem that the patient had on their medical history, with a possible exception of the Depo-Provera shot, where they say generally risk benefit ratio favors use of the contraceptive. So this is actually a really extensive table, and it comes along with an entire summary statement. And so I thought it was really neat to look at, and for somebody who may have a couple of different medical problems to refer to when they're talking with their providers and thinking about what would be the most appropriate type of contraceptive. So let's talk about menopause. So menopause generally reflects the period of time in our lives when our estrogen levels begin to decrease and lead to a relative estrogen deficiency, or a disproportionate amount of male hormones. So this little graphic of this woman starting at age 20, the area in pink in her body is representing the sort of general level of estrogen in her system. and it kind of peaks somewhere around age 35 and then slowly starts decreasing over the subsequent decades to the point at age 80, we actually have a relative deficiency of estrogen and a predominance of male hormones. And so it is this estrogen level in this period of time that is felt to be the protective factor that that women don't experience as much heart disease as men do in their 40s and 50s. But by the time we reach age 60 and 70, those proportions are actually quite similar because of this decline in the estrogen level. So it's important to think about menopause that it does not cause cardiovascular disease, but we experience many changes in our bodies as we go through them. And a lot of those are things that can contribute to cardiovascular disease. One of those things is this decline in estrogen levels, but it also may include things like increased cholesterol levels or stiffening or weakening of these blood vessels that we referred to, or physical inactivity as we start to develop arthritis and maybe we don't run as much as we did before, or the increased risk of the metabolic syndrome. And so overall, the other factors that tend to go along with menopause are the things that increase someone's risk for developing heart disease later on in life compared to just menopause in and of itself. So are transgender people at increased risk? I think this is a really interesting question. First, just in case there's people who aren't familiar with the terms, I think it's important to define what the terms transgender and cisgender mean. So cisgender refers to people whose gender identity matches the sex that they were assigned at birth. So a cisgender woman is somebody who was assigned female at birth and identifies as female, and a cisgender man was assigned male at birth and identifies as male. Whereas a transgender person defines somebody who does not identify with the way they were assigned originally at birth. And so a transgender woman was medically assigned as a male at birth, but identifies as female. And a transgender man was medically assigned female at birth, but identifies as a male. So some retrospective studies have suggested that we do need to think a little bit differently about these folks compared to cisgender patients, in that transgender women who were assigned male at birth but identify as female, they've been using, for the most part, they've been using some gender affirming estrogen therapy, typically during their lives, which may actually negatively impact their cholesterol levels or rates for diabetes. And so these folks likely have a higher rate of cardiovascular disease compared to their cisgender counterparts. Whereas transgender men, it doesn't appear that they have increased risk for cardiovascular disease. And that may be that the masculinization hormones that they use may worsen their cholesterol levels, but have a positive or neutral impact on their blood pressure or diabetes. And so those risk factors may tend to balance each other out. And so I do think it's important to think about it in all scenarios in terms of the hormones, both endogenous and those that people take. So I know everyone's really curious about CFTR modulators, and unfortunately, this is my only slide about modulators because there's just not a lot of information out there. Despite being, having ivacaftor approved in the US since 2012, we do not have a lot of details about long-term outcomes as they relate to cardiovascular disease in the context of CFTR modulators. Likely because ivacaftor was only approved for such a small number of folks that it was not, an outcome that anyone really thought to look at. But I think that most of us would probably agree at this point in time, we would fairly safely say that CFTR modulators do seem to contribute to weight gain in some senses, in some cases, medically necessary weight gain, but in some cases, people have gained more weight than they were anticipating. There does seem to be some suggestion that it can relate either positively or negatively to both mood and or stress, which, as we talked about, may also impact the development of heart disease. And then certainly it has been one of the key factors that has helped in terms of raising the median age of people with CF. So people are getting older while taking these medications. And those all seem to be things that may promote development of heart disease. But there's lots of things that we really just don't know about. We really don't understand very well how a CFTR modulators affect gut absorption, and thus the food that you ate, right? How much more, how much more of those fats are you absorbing? And therefore, how much more cholesterol is your body either producing naturally or are you taking from the foods that you're eating? And that really hasn't been well defined. I can tell you just anecdotally speaking about blood sugars. I've had some folks who are newly diagnosed with diabetes shortly after starting modulator therapy. And I've had other folks who are like cut down on their insulin way down. Like they don't require nearly as much insulin as they used to. And so it doesn't seem, we haven't yet identified who's going to fall into what category. And certainly inflammation is probably going to play a major role, right? As we decrease the chronic inflammation in the lungs and the chronic stress on the lungs, that's probably going to be a protective risk factor against the development of heart disease. And so I think that the jury is really still out in terms of the overall net benefit of CFTR modulators on heart disease. So let's briefly delve into some symptoms. This, gets advertised on TV shows and whatnot, and so it's probably not news to anybody. But sort of classic heart attack symptoms are generally described as chest discomfort that may go away and come back. It can feel like pressure or squeezing. It can sometimes wake you out of sleep. It sometimes actually moves up into the jaw, the back, or down an arm, although maybe less classically in women than in men. You may experience shortness of breath, nausea, cold sweat, or lightheadedness. And for a stroke, typically people would talk about symptoms including a facial droop or weakness of one side of the body, one arm or one leg, and speech being slurred or difficult to understand. Those would be symptoms that we would be worried about a stroke or a transient ischemic attack in. But really, when it comes down to it, there's no good way without diagnostic testing to tell just based on symptoms what's causing those symptoms. And so minutes really do matter in these cases in terms of saving heart or brain tissue. And so the most important message that I can probably get across is that whenever you're in doubt, a lot of us have that sort of sixth sense that we just, are like, this just doesn't seem right. This doesn't seem right. And you may know your body really well in terms of, how your pulmonary exacerbations present or, what your pulled muscles feel like. But if it doesn't seem right, it's the best thing to do is to just get it checked out, because they can do some diagnostic testing and determine whether or not it is related to blood flow access to your heart or your brain. So we can do some things to reduce our risk factor for developing heart disease. Balancing calories and physical activity and eating a variety of fruits and vegetables in our diet. I really like this infographic from the American Heart Association, which breaks down the vegetables that are best at peak freshness in the various seasons, so that we can adjust our eating accordingly and shop for seasonal produce, which A, is less expensive and B, better for the environment. And may include some things here that you hadn't necessarily considered when thinking about vegetables available in the fall and the winter. Choosing minimally processed foods, not a lot of added sugars, not a lot of added salts or alcohol, limiting alcohol. Those are all important factors for improving your heart health. And so now you're probably saying to yourself, wait, even in CF, I thought I've been told for 35 years now that I have to eat a high calorie, high fat, high protein diet. And I have to take my ivacaftor with 10 grams of fat or more. And, I have to eat more. And the answer is yes, that's all been true. But this is one of the crucial things that I think that we're going to be seeing changed over the next few years as we understand just how much modulators change how food is absorbed in our bodies and used. I think that most of us would agree that the dietitians that we've worked with would generally recommend more healthy fats like, peanut butter or almond butter and avocado, right? And not say, Twinkies and burgers, right? Except for if you've got a toddler and that's just about all you can get them to eat. But this is probably going to become more important. I'm pretty sure we're going to end up seeing some new nutritional guidelines coming out so that we can steer folks away from that earlier on in life and make the diet choices that are overall better for them from the beginning so that we're not trying to play catch up as we get older. But it is an individualized thing that you should always talk to your provider team about. I came across these two websites. I'm not sure if these links will work with the screen sharing. Let me see. Are you guys seeing us flip over to a website instead, or am I still on the other one?
We're
No.
still on the other one.
All right, here we go. I'm flipping. Are we good now?
Yes.
Okay, so the CF Foundation has this super great little thing here about grab-and-go meals and snacks, right? Some really good ideas for things that are healthy and yet contain some fat for those that are thinking about it in terms of needing to absorb their modulator, mini meals or ways to eat on the go. So I thought this was really great. And then the other one, just make sure. Are you seeing CF Chef now?
Yes.
Okay. So this one is recipes and meal tips for the CF community. And I thought this was really great in that, it gives you a whole bunch of different options for recipes that you might not have thought of with a real focus on healthy eating. And one of the things that's emphasized here is cooking for, with one family member has CF and the rest don't, we obviously don't want to make, different meals for everybody, right? So we have to make things that are heart healthy for everyone and yet get the person with CF their required nutrients. So I thought this was a really great option too. And then obviously your nutritionist at your center is going to be a key source of information. So I'm going to flip back over to my PowerPoint here. We're just about finishing up. Physical activity, crucially important. That's something that's generally emphasized a lot in general CF care, but thinking about it more as, not just for this is good for your lungs, but this is also good for your heart health, right? To do interval training or to add muscle building exercises are things that we may be promoting more coming in the future. And I think it's really important to think about exercise as a general part of life, as opposed to if I don't get to the gym for 45 minutes, then it didn't count, right? Any amount of exercise in any quantity and in any duration and in any physicality is better than nothing. So if gardening is your thing, garden, go ahead. I know I breathe really hard when I'm weeding a garden. Building it in, like saying I'm somebody who takes the stairs and doesn't take the elevator, assuming that your lungs are healthy enough to handle that and or working your way up to that is a really great way to get in exercise within the normal day-to-day life and not have to set aside extra time for exercise. And then thinking about advocacy and education, these are just a few of many resources that exist to really focus on this high incidence of cardiovascular disease in both men and women across the country, and ways that we can bring heart health care to those that are underserved or underprivileged, particularly like this one called Wise Woman, which is well integrated screening and evaluation for women across the nation, and A Million Hearts is also really a great resource. And so there are definitely opportunities to get involved and pair up with experts in the field. So unfortunately, we still have more questions than answers, which is common in medicine. There's lots of things that we don't know. These are just some of the points that that my colleagues and I had pointed out, and when we published that paper about our patients with heart disease, is that we really don't know much about screening for high cholesterol in patients with CF. And so unless you have CF related diabetes and you've been seeing an endocrinologist as well, you may never have been screened for high cholesterol. We don't know whether thresholds for starting cholesterol lowering medications are the same for people with CF versus those that are not. And we don't know about how modulator therapy may impact both cholesterol, lipids, and inflammation. As people get older, we don't know about what the natural course that we are to expect in cardiovascular disease, right? Are we going to start seeing lots of cardiovascular disease? Is it going to increase and mimic the general US population as our diets, if our diets remain heavy on the fats and lower on the fruits and vegetables side of things? And we also need much more information about drug interactions with modulators and some of the traditional medications for heart arrhythmias or cholesterol. So just to close this out with talking about our patient again, when my fellow called me and said, hey, I got this call from this patient and I'm worried. I sent her to the emergency room, and then we found out that she was actually having a significant heart attack. We went back and we looked at her history a little more closely. And we discovered some risk factors that maybe weren't obvious on first glance, that she had been prescribed the triple combination of lexicaftor, tezacaftor, ivacaftor, and had been on it for about 1 year. And she had gained about 15 kilos on that, which is approximately 30 pounds or so. And that was all necessary weight because her body mass index went from about 18 to 20, but it's still a lot of weight for a single year of gain in any one individual. She had a personal history of high cholesterol and was on cholesterol lowering medicine. And she also had a family history of high cholesterol and early heart disease. And so this was something that was, a risk factor for this particular patient. And she also had been seeing endocrinology. She had really longstanding, very difficult to control diabetes through no fault of hers or her providers. It was just really brittle diabetes. And so she had some really impactful risk factors that in retrospect, we probably should have considered more closely when thinking about what her chest pain could be attributed to. And so she was treated in the hospital and had 2 stents placed in her heart. She was started on blood thinner medication to decrease the collection of blood clots, or the potential for her to develop blood clots in her arteries. And she was discharged after about a 5-day hospital stay with a resolution of her symptoms and improvement in her heart function. And she was completing a heart cardiac rehab program afterwards. And so overall, it was a bad situation for the patient, but fortunately a good outcome for her, and really food for thought for the rest of us about how to approach similar cases in the future, where you wouldn't necessarily think about in a 30-year-old patient. And so with that, I will stop, and I'm happy to entertain any questions. Thank you so much for your interest. And I'm going to stop sharing my screen.
Thank you.